Hello and welcome to the EMDR Maven podcast. I'm Julie Miller and I'm an EMDRIA approved basic and advanced EMDR trainer, an EMDR Institute regional trainer, and an EMDRIA approved consultant and certified EMDR therapist. I provide training through the EMDR Development Center, and you can learn more about that at the website emdrdevelopment.com. You can also check out all episodes of the podcast at emdrmaven.podbean.com. In each podcast, we'll have a question of the week to be discussed, and these can come from new and experienced EMDR therapists like you. We'll talk about a research study of particular interest in EMDR therapy, and we can talk about books, equipment, and ways to be creative to get EMDR therapy to work for your clients. I have advanced training information available through the EMDR Development Center website, emdrdevelopment.com. So send me your questions, your ideas, any resources you'd like to share with others, and any kind of request related to EMDR therapy so we can make this an interesting, fun, and educational time together. Let's get started. We have special guests today for our podcast episode. The question is about the use of EMDR therapy with OCD. And who better to go to than the experts Paula Krentzel and Jennifer Tattersall. Paula Krentzel, PhD, is a practicing psychologist. She's a certified EMDR clinician and an approved EMDR consultant. She's been a practicing psychologist for 30 years. She's also a facilitator for the EMDR Institute in basic trainings. She was trained at the Massachusetts General Hospital and Children's Hospital in Boston, Massachusetts. Her areas of expertise are developmental and complex trauma, anxiety disorders, specifically obsessive-compulsive disorders, attachment disorders, chronic medical disorders, and depression. Dr. Krentzel developed the distancing approach, which is a comprehensive EMDR treatment for OCD. She presented the approach at EMDR Canada and presented with Jennifer Tattersall at the EMDR International Association Conference in 2021. She and Jennifer Tattersall have published several articles on OCD and EMDR. They are currently preparing an article on dual treatment of PTSD and OCD. Jennifer Tattersall is a licensed clinical social worker. She's also a certified brain injury specialist and a co-occurring disorders professional. She's certified as an EMDR therapist and an EMDRIA-approved consultant. She was previously the clinical preceptor for the Groton, New London Naval Submarine Base, Substance Abuse Rehabilitation Center, and specializes in working with adults with trauma, complex trauma, OCD, and substance abuse. Jennifer is a co-presenter of the distancing approach, which is an enhancement to the standard EMDR protocol, and it continues to be taught internationally. Dr. Krentzel and Ms. Tattersall have established the Krentzel-Tattersall psychotherapy trainings and train clinicians on a variety of psychotherapy treatment topics. So let's welcome Dr. Krentzel and Jennifer Tattersall. So welcome, Jennifer and Paula. So happy that you are here to join us. And I have a question from one of the listeners of the podcast about the use of EMDR with OCD. So they just wanted to know if OCD can be treated with EMDR therapy. So this is your guys' area. So what is it? What do you have to say to that person who wants to know?
Why don't we define OCD first, exactly what it is, because I want to make sure that we're using the same criteria. And then we'll move into how we treat OCD with EMDR.
Sounds good.
So OCD, for it to be a clinical diagnosis, the person needs to be engaged in distressing and interfering habits, and we'll talk what those are, for at least an hour a day for it to be clinical. You have subclinical where it doesn't interfere with their life. So OCD is recurrent intrusive thoughts, images, urges, sensations, and they lack clear purpose. And clients often know that they're irrational. but they can't stop them. It has this loop. And
Mm.
repetitive behaviors or compulsions the person cannot control they're compelled to act in a particular way and to release distress. So you have a trigger or you have some kind of stimulus, and from the stimulus, you have a thought. And then with OCD, you have a catastrophic interpretation. From that, there builds anxiety. And to lessen the anxiety, they engage in compulsive behaviors. And that is to prevent the feared consequence or the feared
Mm.
outcome. But it
Mhm.
only lasts for a few seconds. And then again, there's another obsession. So you have this circle over and over and over again. And so that is the definition that we use for obsessions and compulsions. The other thing that's important to note is that compulsions can be external, and we all know about washing hands and we know about checking, but they can also be internal, involving images. Like somebody, who had postpartum depression, had to have the image of the knife because she was worried about a knife in her daughter's back. That was kind of with a belt on her thigh, so she couldn't touch it and could spend 45 minutes with that internal compulsion. Yeah.
And just echoing what Paula is saying, individuals do get a sense of relief for performing the compulsion. However, it's very minimal. And
Mhm.
unfortunately, it reaffirms and continues the OCD. So it continues that neural pathway and it really ingrains the OCD.
And the
Got
more
it.
you engage in the OCD and your family, we'll talk about this a little later, and your family accommodates and allows you to engage in the OCD, the worse it becomes.
Mm. It's kind of like ruts in a road, right? The brain gets used to this, it likes
Mhm.
consistency, and so this is the habitual way in which the brain is working. Makes sense.
Actually, Julie, I'm so glad you brought that up because not only it wants consistency, it wants certainty. People with OCD
Mhm.
want certainty. They have the
Mm.
obsessions and compulsions again to prevent a feared consequence, but it's an irrational consequence, and they want to believe that there's some certainty with this. I had a client who she'd have to say a prayer a certain way because she believed that her family would die like an unexpected, difficult death. So that was her feared consequence.
Yeah, that makes a lot of sense. Yes. Okay,
And she
good.
wanted certainty that if she did this, that this was going to prevent her family from dying.
Right. So,
Again,
so yeah, that
They
makes
have to
sense
do.
to me. It's very different from certain addictive behaviors that are all
Mhm.
about finding a positive feeling state. So it's looking for something positive as opposed to preventing something
Mhm.
bad from happening, which is more like OCD.
mhm.
Mhm. And it's preventing something in the future from happening,
Right.
not in that moment. It's about the future.
Also, just, one of the hallmarks of it is that whatever they're trying to prevent does not fit the situation. Like if someone said this prayer, this individual said this prayer, it was going to be able to create some certainty that her family was not going to die. The two do not connect together. So when clinicians talk about, oh, I have OCD, and it actually, the situation kind of makes sense. That's usually clinically not OCD. That's something
Mm,
else that we're talking about. It
mm,
might be anxiety, it might be another disorder. But whatever they're trying to prevent actually doesn't fit with the situation. I had
hmm
somebody who, unfortunately, she was traumatized. She believed if she stopped knocking on a piece of wood, that God would stop doing things to her. And again, the knocking wood and having God save her or prevent her from horrible things, the two don't match up. So again, that's
hmm
just one of the things to look for. It doesn't match up. It doesn't make sense.
Right. It's
Mhm.
sort of like in behaviorism. I've studied behaviorism. And in behaviorism, superstitious behavior is when two things that aren't related or actually connected accidentally get reinforced and wired together, like a black cat crossing your path.
Mhm.
Like maybe one time, about 1,000 years ago, somebody had something bad happen after a cat crossed their path. So is it kind of like that sort of process that things get paired together that don't really fit together and they're irrational?
Mhm.
Mhm. And often the client, which we talked about a little earlier, knows it's irrational.
Mm,
There's a little part of them that knows that,
mm,
but then the OCD takes over and keeps making them question their rational thought.
mm,
So they continue to engage in the OCD behavior and the
mm.
OCD thinking.
Mm-hmm. Yeah, makes sense.
Paula mentioned something earlier I think is really important when we're talking about OCD is the one of the diagnostic indicators is insight. And if a person has poor insight into the disorder, they will have a poor prognosis and
Ah,
treatment outcomes are less positive. So
mm,
the more insightful they are, the more they understand that even though they're doing this behavior and it's causing distress, if this doesn't make sense to them in some way, they have a better chance in treatment. Some people don't realize what they're doing. I was working with somebody who had relational OCD, and she had no idea her desire for validation was OCD. And she didn't really, she had a really hard time believing that it was OCD. Every time that we talked about it, and I would say, "What is that?" She would say, "I'm not really sure." So her treatment outcome was a little bit um, less good.
I have a client, a new client, and what I found really interesting, and Jennifer, I'd like to hear what you have to say. So the first several weeks, he was coming back at every time and he said, I realized that this is also my OCD and this is my OCD. Like he started as soon as I did the diagnosis and he started to say, you know what, it really interferes with my life. And all these behaviors I never thought were OCD are. And so his insight was minimal when he started, but within like 3 weeks was extremely high. And he's working so hard, and we've only been working together like 6 or 7 weeks, and there's a lot of improvement already. So it just reinforces what you were saying, Jennifer.
When you're talking about it, it sounds like you did a lot of work with psychoeducation and also
Mhm.
as the therapist, making sure that you point out the OCD in session, which helps people develop insight. So we can start with a poor prognosis. However, people can develop insight over treatment. So when we talk about OCD, there has been some previous research about the effectiveness of EMDR on the treatment of OCD. In the Mars article in 2012, what is really important about this study is the fact that all four participants described experiencing symptom improvement within the first 2 to 3 sessions. That is significant.
mm,
These individuals suffered with disabling OCD for many years. Remember, disabling over an hour a day, and attempted various other CBT strategies without achieving any relief. After 14 to 16 adapted EMDR individual sessions, each participant, all four, reported significant improvement and a large decrease in distress, with the effects of treatment being maintained for approximately 4 to 6 months after follow-up.
nice.
And there's two other studies. One was by Marsden in 2018. These are the more recent studies. And they compared EMDR with ERP. And ERP is kind of like the standard exposure and response therapy, actually. Their results showed that both treatments significantly reduced OCD symptoms at post-treatment and 6-month follow-up. And there is no difference between EMDR and ERP conditions. And another study was Serachlu and colleagues, and they compared 12 sessions of ERP to 12 sessions of EMDR and ERP for 60 participants. The treatment given, that group that was given EMDR and ERP, was alternated with Mars protocol. And Mars was someone who did research quite a long time ago. 1 week and then ERP the next week. Results showed that EMDR and ERP were significantly superior to the ERP alone. And there
Mm,
was also a high rate of therapy completion in the EMDR and ERP group.
mm,
And so we're building off of those research studies. And what we find in terms of what you had asked earlier about phases, the phase one is history taking. It's a little different because you want to do the Y box two, which is the Yale Brown Obsessive Compulsive Scale, and you want to do the second version. I also always give a Beck and a GAD-7 to determine is there underlying depression and what their level of anxiety is. You want to take a history of all OCD behaviors, both obsessions and compulsions, and a family history of OCD because it often runs in families and there is a genetic component. It's kind
mm,
of like you have a genetic component, there's a setup, and then there's a stressor. And it kind of like then, the OCD shows up, a major life stressor, such as like birth of a child or moving or getting married. I know somebody who got married and their OCD just like blossomed right after the wedding, and went back actually to England to check something, like even flew back because the OCD was so
Wow.
intense and was
Yeah.
not getting treatment, was in a group um, that was actually reinforcing the OCD rather than saying, this is OCD, you don't need to go. And by going to Europe, going to England, reinforce the OCD. So you also want to get family involvement. We want to know, what is the family doing? Does the family allow the OCD? Have they changed their life? So this is called family accommodation. So we want to determine, and there are scales for family accommodations. There's the FA, family accommodation scale, the FAS. So that's a really good scale to determine what the family is doing. I have a client who went on vacation, and she said, they were going to be on a boat, and the mother said, you have to keep your bathroom time low, because that's what this child's OCD was around, contamination. And she said, well, the rest of the family can just, there's other bathrooms on the boat. And the mother said, and I was so proud of her, she said, no, they cannot use that. You're going to need to be as respectful as you can. You have one bathroom, versus saying, sure, well, I'll go to the other, we'll go find another bathroom. That would have been encouraging and accommodating to the OCD. Also, it is linked to the AIP model. And so we are reinforcing new adaptive thinking with the OCD. And it does start with education. That's the first step. But I'm going to have Jennifer really talks about the stages of change quite well. So I was going to have you talk about that.
So this is a model in the addictions world that comes from Prochaska and DiClemente, and they talk about pre-contemplation, contemplation, preparation, action, and maintenance. And these phases help determine where people are in their treatment. So you're going to see if a person is actually at a phase of treatment where they want to take some action regarding the OCD. Sometimes people do not. An individual that I worked with needed reassurance from her family members, and she didn't want to stop getting the reassurance from her family members because she thought that if she didn't get the reassurance about if they still loved her and cared for her, that would just be devastating for her. So she didn't, she was in the pre-contemplation, contemplation. She saw it as a problem, but she didn't see it as a big enough problem to prepare or to take action on it. So it's really important to understand where your clients are in the stages of change. I even think about myself as a new therapist, when I thought people were they would come in and there was a part of them that would be in the action phase and say, oh yes, I want to work on this, but I didn't realize there might be another part of them that doesn't. So if we're ready to prepare for action and the client fully isn't in action, it's going to be a misattunement, and the client might not be able to come back, might not want to come back to treatment, which is especially unfortunate with OCD because it takes people a very, very long time to come into treatment for OCD. There's a lot of shame that's related to it. So again, you want to be attuned to where they are, and even if they're in a pre-contemplation or contemplation phase, you can help move them towards preparation and action.
Jennifer, I'm glad that you brought up the idea of shame, because we teach the distancing approach, and the recording of the college student throughout the entire training. When I met with her the first time, it took her 20 minutes of just just talking to me, and she just couldn't tell me what was going on. And finally I said, listen, I have two possibilities of what you're trying to tell me, but that's so hard for you to tell me. And I threw them out, and she said, yes, she had aggressive OCD. And I've never had anyone do so well in treatment as this young woman. I mean, she was within like a couple months, she was done with her OCD work, and we did other work. Typically, I have somebody now I'm seeing a year and a half, and she's doing so much better, but it takes typically a longer period of time than this client that people get to see. But it's really about the shame, and it's about the amount of distress that they feel. And I don't know if people understand that. And that's what's so nice about watching these videos that we continue to use.
Okay, so when we're talking about phase 2, after a person's been diagnosed, or you have an idea that there's potentially, even if you haven't done the Y box and you have an idea that there's potentially OCD, you're going to offer some psychoeducation. There's some really good places, the International OCD Foundation, they offer a lot of good psychoeducation on OCD. Again, that will help mitigate the shame in your clients. You're going to make sure you're going to assess for any co-occurring disorders, making sure you're having a diagnosis that not only reflects PT and OCD, but if there's any other comorbid diagnoses like PTSD, because PTSD symptoms can look like OCD at times. Paula and I are going to be doing a training on that at another time. You're also going to have the client identify OCD in session. If you're seeing it as a clinician, you are going to identify it with the client. And you're going to help bring present moment awareness to what is happening in session in that moment. And you're going to bring their mindful attention to the OCD. So if you see someone in session and they're engaging in OCD behaviors, you have to say that's the OCD. In terms of resourcing can look a little bit different with OCD because we want to make sure that there's still some activation. Clients can use resourcing at times to avoid the OCD, which we don't want to do. So, like, for example, some relaxation techniques can actually increase the OCD because it's just avoiding it rather than focusing on it and treating it. And also being able to name the OCD as a part. And sometimes people can realize that the OCD is a part of themselves. And there's another part, maybe a rational part or a wise part, that can realize that this is OCD rather than just having it blended into their whole self. And again, it's really important to reinforce the therapeutic relationship because, like Paula talked about, with the amount of shame that someone has, they're going to want to be able to tell you if it's aggressive OCD. Some people have thoughts about hurting someone they love or a pet, and they would never be able to express this to a family member because the family member might be scared or upset. But you have to have a strong therapeutic relationship and be able to regulate yourself as a therapist because some of the things that people are going to tell you might be disturbing. And Paula and I just wouldn't mind taking a moment with this. Paula and I always get the question of how do you know somebody is not going to hurt themselves or hurt someone else instead of it being OCD? And it's important to note people with OCD, again, have a great amount of shame. There's a greater amount of remorse. And it really, and it's really difficult for them to talk about. Paula, did you want to say anything about that? Because we do talk about that quite a bit.
And there's a lot of distress. It's like, how can I think this? And so the other thing is that when they begin treatment, and this is going back to phase one for a minute, is that somebody can have intense OCD, extreme OCD, but on the Y box 2 appear like it's there. It's more than an hour a day. On the Y box 2, anything over a 13 is OCD, but it comes out to be a 21. It goes up to 50. However, this person with extreme OCD, if they really answered it authentically, it would be like a 40 because they're obsessing all the time. They can't stop the obsessions. They don't have obsessive-free moments. And that's why, Jennifer was talking about relaxation. If somebody's just working on their breathing and noticing the thoughts and they let the thoughts come in, those thoughts just keep swirling around and around and around.
Another part of phase 2 in the therapeutic relationship is that we cannot offer reassurance in the same way. I've seen, and I know Paula and I have talked about it with consultees. Sometimes consultees want to be able to be that attuned, caring, loving trauma therapist who wants to validate. And sometimes we're validating the OCD. I remember, this is one of my favorite stories, and Paula and I tell it when we talk about the distancing. I had a client who, again, was very scared of losing connection with her family. And she would ask her family all the time, are we okay? How are we doing? Are you mad at me? And at first I was like, your family loves you. You have a great connection with your children. And then I realized it was relational OCD. And I remember calling Paula and saying, Paula, I've been in reinforcing this person's OCD, and I didn't realize it was relational OCD. So again, offering reassurance in the way that says, oh, yes, we can focus on working on your OCD, but we're not going to validate them in order to create certainty. So we can support without reinforcing the OCD.
I have a client who also has relational OCD and needs a lot of reassurance that they're okay with their partner. And then, we talked about, not checking in and, are we okay? And what this client did is turned and said, I'm going to go do blah, 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 whatever it was, and waited for their partner to say, oh, okay. And that was the reassurance. And what came in and said, I'm kind of finding a way to get around what, my homework, which is, agreed not to ask for reassurance like 10 times a day. And so it's like you have to be very aware. There's a little sneakiness, and it's not intentional, but what Jennifer was talking about earlier, that insight, this client had enough insight to say, this is like our third session, I'm doing workarounds. He didn't call it that, but that's what he was doing. We'll talk more about workarounds a little bit later.
And sometimes safe place or calm state's a little bit different, can be another way to avoid OCD. So you have to be really clear about what you're working on, be really focused on working on the OCD. So, and a person, sometimes even if we wanted to reinforce a calm place, a person with OCD can't always access that calm, because when someone is having obsessions and compulsions, they're out of the window of tolerance, and that is highly distressing.
And therapeutically, using a resource or teaching a resource to help them get back into their window of tolerance is so helpful to them. So it's so important that, Jennifer, what you had said earlier is that you need to state what's happening in the session and to understand that.
And Paula, just piggybacking on that, the resource cannot increase the OCD behaviors and cannot be a way to work around the treatment or have any avoidance of the treatment. I was working with somebody, and we were working on something, for her first memories of having OCD. And I thought things were going along well, but I found out that she carried a piece of wood in her pocket and she was tapping it as we were working on it. So again, as part of your assessment phase, you have to make sure that they're not doing any OCD behaviors of obsessions or compulsions that is going to cause the treatment to be less effective. And I wouldn't have known this unless I asked her. And then at subsequent sessions, she wouldn't volunteer this because she thought if she didn't tap the piece of wood, terrible things were going to happen. So I would have to ask her, do you have the piece of wood in your pocket? And then I'd have her take the piece of wood out of her pocket so she couldn't tap it. She needed to feel the distress of it rather than reinforcing the OCD.
Yeah, that was what my question was, with how did you find out that she had a piece of wood in her pocket?
Actually, I said, is there something going on? Because I noticed like she was doing something and I was like, what is actually happening here? And she goes, well, I'm tapping the piece of wood that I carry in my pocket. And again, I wouldn't have known that. I just asked a question because I saw something in her movement I didn't know what she was doing because we were on Zoom. So that she told me. Thankfully, we had a good enough therapeutic relationship where she told me what she was doing. But those things can happen all the time. People can be tapping their feet. If you're on Zoom, you're not going to be able to see their body. So they can be tapping their feet. They can be tapping the table. So you have to ask, is there any other behaviors going on as we're working on this?
And really tune into what's going on with the client in your office.
Mm-hmm. And what I love, what you just talked about, Jennifer, is this moment-to-moment tracking. That when you're working with OCD, you're doing moment-to-moment tracking, which is exactly what you're doing in that session. You notice something and you asked. So you're very attuned to the client's behavior. And what you talked about a little earlier, which I totally agree with, is that attunement in this sense is very different than attunement with a trauma therapist. That attunement means not allowing the OCD behaviors to continue in your office and pushing a little bit, not too much, but just a little bit. Phase 3, we have assessment. And so we follow Francine's phobia protocol, where you want to know the first event, the worst, the most recent activating event, and triggers. Triggers are really important. You may need to use flash forward on fears of having OCD or focusing on a feared event. One of my clients was incredibly fearful, had health-related or continues to have health-related OCD, but it's doing really well now. In the beginning, she had fears that she would be in bed, in a hospital bed, and her husband and her son would be over here on the opposite ends of the room, and that she couldn't be there and that they would leave her. And we did a flash forward on this image, and she realized, this is irrational. My husband's not going to leave me. I'm working really hard to get better. That's just not going to happen. So we don't know if they'll ever get divorced, but what we do know is he's not going to leave her at that moment because he was incredibly supportive. So that's the other thing when you're doing OCD work, not necessarily in the assessment. This is probably more Jennifer. You can talk about this in a second, is that you can't promise anything. So if people have existential OCD, it's like, I can't promise that, everything's going to be okay. All I can say is, what do you know at this moment? I can't promise that, your family's not going to die. I can't promise that you won't get into a car accident. All I know is what I know right now, which is you are okay, you are safe, and your family's safe. I can't predict the future.
There was a client that I was working with recently who has OCD around her closet doors being open. She believed that if her closet doors were open, somebody was going to sneak in her house and assault her. She has no trauma history. I did a thorough assessment. So we focused because I noticed when we were working on it, it was really hard for her to move past checking her closet doors. We focused on the future feared event of her being assaulted. I had her hold that in her mind, and she said, it would be awful, but I was able to get through it. And the other day when I saw her, she goes, ugh, the closet door thing, I can't even believe I had those thoughts about it. So we're working on some other areas, but when we used the feared event in the future, that really helped her distress and helped her move into the work on the OCD. Desensitization, phase 4. So if you're using the distancing technique, which we're going to talk about a little bit later, you're going to be developing some adaptive coping statements to help clients. And those adaptive coping statements developed in phase 2 are going to be your interweaves for the distancing. So they're going to create these statements that help them treat, manage the OCD. And we're going to be using them in standard protocol. And we're going to use a resource like an adult self or a wise self, because we want to be able to help all parts of self. Sometimes if a person is traumatized, they may have a younger part of self that has OCD. Maybe all parts of self don't have OCD, which can be really an interesting thing to treat. However, we're going to use it in a resource like your wise self or your adult self or your most actualized self to help the client manage the OCD.
What you're just talking about is really important because that part knows that it's OCD and it's not rational, which kind of circles back to the beginning of the podcast. So when you're dealing with the adult self or the wise self or the future self, it's so important for your client. Okay, so installation, that's phase 5. You're going to install the PC, the positive cognition, and try to generalize to all the work that you're doing. And if not, you can just say, if it's not generalized on this event or this trigger, where's that PC? And you often get a 7. And it takes time for someone to generalize their positive cognitions.
So phase 6 of the body scan. So we're going to use this in the standard way we normally do. But we're going to ask if there's any OCD urges or sensations in the body also, because we don't want to miss that. Because sometimes when people have thoughts and we're able to track the thoughts and work with the thoughts, they don't have the thoughts anymore, but they may feel a sensation. I was working with somebody, she would have sensations in her body and she would believe if she had these sensations, she was going to have a heart attack. She was a healthy individual. She was cleared by doctors. There was no indication that she had heart problems. I wouldn't say this to somebody who did, but it didn't make sense that she was having a sensation and then she immediately thought she was going to have a heart problem. But that was OCD. Her compulsion would be to go research. Does this sensation correlate to having a heart attack? During this, I had to ask, are there any urges? So don't forget to ask those things because they can make a really big difference in being able to install a positive cognition or having a clear body scan.
So you bring up an important point. So when you're doing desensitization, even though we're just talking about body scan, so if somebody has a sensation and they're like, and I think that I'm having a heart attack, it's like, what's happening right now? What do you know? So you're trying to bring out, their resources and their rational thinking while you're doing desensitization, which we keep mentioning the same thing over, Jennifer, I think mentioned it, I mentioned this, but it's important to know that when you're doing desensitization, you want to bring up those resources, what that adult self knows. It knows that it's not a heart attack. What did your doctor say? The reassurance would be, you're not having a heart attack. I know you're not because I know what your doctor said. An interweave would be, what did your doctor say? Which is very different. So they can pull up that information.
Additionally, it's something that they can take home with them too, which we'll talk about during closure. So with that, you're going to ask the client what they're leaving with, and if they have developed adaptive coping statements or resources, they're going to utilize that when a thought, image, or sensation or impulse arises, and not if. It's going to be when, because under stress, OCD symptoms come back.
One of the things is we don't talk about exposures when we're working with adults. We do talk about it with children. And actually, I do talk about it. That's not true. I will say, every time, Jennifer just said, you need to know what their adaptive coping statement is. A lot of people, one that works really well for my client with health-related OCD is, if I don't give this attention, it's going to go away. It's just going to pass. And so every time that she has a sensation and she says that, that's an internal exposure. And so they are to live what ERP clients, clinicians call the exposure lifestyle. And we've never had, and I have Jennifer to speak to this, I've never had someone use their adaptive coping statement as a new OCD statement. It's never happened. And so we talk about, when you're working with OCD, you want to be at the highest level of their window of tolerance right before they go over. And it's like they're going to be at the crest of the wave and they're riding this wave.
And Paula, I agree with you. I've never had anyone use any of the resources or any adaptive coping statements we've developed as part of their OCD. Reevaluation phase 8. So we're going to ask the client when they come back in session with us about how they've been, what have they been doing during the last time since we've met, and also specifically about any changes with the OCD or in any other behavior. So I have been working with somebody recently who has OCD around cleanliness. And we were working on something not related to her picking up papers. She gets really dysregulated if she sees papers. And we were working on a very traumatic event for her when she was younger. Unfortunately, her mother has OCD also. And she came in and she said, my son was working on a project at the kitchen table and he had his papers all strewn out. And at first I went, ooh, papers. And then she said, oh, this time is fleeting. It's so exciting to see him doing his work and sitting at the kitchen table. And I'm going to remember that. And I'm not going to remember all of the papers that were strewn about. And this came about organically since we had been working on the OCD. And I didn't target that specifically. We didn't target anything to do with papers being all over. But this was what shifted. And because OCD was able to generalize, because EMDR is able to generalize, and there was a change in this behavior that she didn't expect. She was so grateful to be able to have this time with her son. It was able to bring her back to what we were talking about earlier, present moment awareness. And she didn't lose time thinking about how she had to reorganize these papers for her son. She just was able to look at him and feel really grateful and feel how sweet that moment is to see him working on this project.
What I think what you just said is that just like with EMDR, in between sessions, things change, which is so important for people to hear. I have a client who I no longer see, she's doing really well, also has OCD, child has OCD, but hers was aggressive OCD. And she was putting a daughter to bed. And she said, I just wanted to take that pillow and put it over her face. I was so annoyed with her. I think just that's a normal mother thing to say or to think. And I was like, yay, good for you. That's great in my head. And I was like, yeah, you just had a thought, you dismissed it, and you moved on. And that's because we've been doing so much work around having these aggressive images.
So also you're going to assess for any avoidance behaviors that we talked about earlier. Like for my client, if she gave up the piece of wood, and then adopted something else, that would be an avoidance behavior. And also family accommodation. It's also part of our phase 2 is being able to offer some psychoeducation to the families also. Sometimes it's really important to even give them a script about what they want to say or what they should be saying to help not reinforce the OCD. So you're going to check for any family accommodation, any other avoidance behaviors like we talked about. Paula talks a lot about workarounds. I love the story about the kid. Paula, would you tell that story?
I will. I have a kid who has contamination OCD, and she is not supposed to wash her hands at certain times. She can wash her hands before she eats. She can wash her hands after she goes to the bathroom, but that's it. And so it was after dinner. It was not because she could wash them before dinner. She wanted to wash her hands. And what she did is she walked around the kitchen, found a tissue, blew her nose, and said, "Now I have to wash my hands." And the parents like, "Oh, no, 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 no. You do not get to wash your hands right now." And that was her workaround. And the fact that these parents really understood that this was a workaround, it's like, I'm going to see what I can get away with, was really good. And also, when we're doing the adaptive coping statement, when we develop them, we also develop them with the client for their family members. So what do your family members say, particularly if you have children or like you make contracts? So if somebody has contamination and they want their spouse, let's say, to wash their hands many times during the day, the spouse contracts and says, like this young girl, I will wash my hands when I come home. At the end of the day, I will wash them, but after I go to the bathroom and before I eat. Other than that, I will not wash them anymore. And so they have to agree to the contract. This is it's just an agreement between the two people. And that also helps. And what they say when they're saying, like, I'm keeping to the contract. I know this is uncomfortable, but right now I'm keeping to the contract for your health, or whatever the adaptive coping statement that the person wants them to say, the client.
Yes, I was thinking about the client that I work with who has relational OCD. And although I didn't work with her family directly, we had to come up with a script about what she was going to say. She was going to tell her family that if she asks for reassurance, for them to be able to say, "Mom, this is just your OCD.
Mm-hmm.
What do you know?" And she was able to talk to her children about that. And that was really helpful. I didn't work with them directly, but this is going to help. It's not going to reinforce her OCD. I didn't want her family to do that because it makes it harder in treatment for her. And
Mm-hmm.
also the long-term prognosis.
So we are constantly doing what we call relapse prevention throughout the treatment.
So we're going to be practicing this at all stages of treatment. And if you're using adaptive coping statements, if the patient's belief both cognitively and somatically are less than a VOCA 7, so if you're using distancing technique, that is how you use it with that. So prior to termination, you're going to reinforce any skills that the patient learned and how to apply them in the future when an OCD thought, image, or sensation is sensed. And again, really being able to educate your clients that it is going to reoccur. It is going to be very stressful. I talk about a situation. My son has subclinical OCD, and he was doing really well, and he can manage it very well. However, he had a project. He was in a health class at school, and his OCD is around contamination. And during this health class, they had the students put oil and cinnamon on their hands to replicate germs, and they would have to wash their hands repeatedly in order to get the germs off. And he came home, and I noticed that there were some more symptoms because he was really activated by this. Also, he had another time where he had a very minor surgery, and he kept asking us for reassurance. And of course, I was going to reassure him because I'm his parent. But I also had to ask him, "What do you know?" And he said to me, he goes, "I know you would never do anything to hurt me, and I know this surgery is because you want to make me feel better." So he was able to use his adaptive coping statements, but I did have to prompt him. And it was to be expected. Stressful things happen in life. People are going to come back to treatment when a stressful event occurs, and they're going to say, you know what, I'm having more OCD symptoms. So at that point, you're going to repeat the Y box to see where they are, because that'll help you determine what kind of treatment is needed.
That's how the client had been talking about, the kiddo who has contamination OCD, the same thing that you just talked about, putting oil and cinnamon and washing your hands over and over and over again at school. That's exactly how the OCD came back. The parents are like, I wish we knew what they were going to do, because I would have said, don't have her do it. And then you need to do some work around triggers, because that would have been a trigger.
So you're going to remind the patient that the intense distress is over, and ask the patient what skills they can rely on when an OCD thought or sensation or image is felt again. That is so important, to be able to establish those statements that they can use when this happens again. And again, like we said, provide education about the reoccurrence of symptoms, and discuss that with significant others, and help them engage in the support they needed if there's a reemergence of symptoms. Also helping that family go back to the script maybe that you've helped them with, in order to help manage the OCD reoccurrence.
And, you talk about families with, relapse prevention. I had one client during COVID, and the family decided she didn't have OCD. And I was the third clinician who saw her, and I thought she needed to go inpatient. And she was just like, no, I don't have OCD. I don't need to. And they were reinforcing her OCD continuously. The last thing we're going to do is talk about distancing, which is a 3-prong approach. So it's a distancing approach. So you have the distancing technique, which is, learning how to distance yourself, and that's what we call distancing. We also have future rehearsal, and then there is the standard protocol as developed, phobia protocol is developed by Francine. So there's 3 different aspects, and you always start with distancing, and then you can move between the others, between future rehearsal and standard protocol. There's times that you can use future template or future rehearsal. We also use flash forward at times. As we talked about, everything we talked about today in terms of the 8 phases, we include the families, we include everything we talked about today. And the distancing, we are beginning to think about doing research on it. We have done our own research, and it has been quite successful, and people don't drop out. That's been my sense, is that people have not dropped out of treatment. So one thing that Jennifer was talking about that I want to comment just about a client, that I have a client that she says, I'm having a sensation. I am just so annoyed by it. I know it's my OCD that's thinking about it, but it's so annoying, versus, oh my gosh, I have a brain tumor. It's a very different thing to think about. It's like I'm focusing on it. I'm just as annoying that I'm doing that, and then I get more annoyed that I'm focusing on it. That's very different. But, when she began treatment, it was like, I have a brain tumor, I got to go see my doctor. The other thing that Jennifer and I talk a lot about together is the difference, and you may want to talk about this, Jennifer, between a compulsion and information gathering. They're very different.
Additionally, sometimes behaviors, we have to decide which behaviors that we're going to work on first, and we have to contract with the client. I was working with someone who, unfortunately, her husband had a diagnosis of prostate cancer, and she was really exhausted when we were in one session, and I was asking her about it, and she said, I've been researching all day and all into the evening about prostate cancer. I said, okay, I understand. And then I asked her, because I do know her history, I said, how many days have you been doing this? She said, I've been doing this since he got diagnosed. So we had to contract around the behavior. So I knew she wasn't going to be able to stop researching. However, we decided, what is the useful amount of research that would be helpful for you? So she was able to contract about an hour to an hour and a half a day. There was a part of her that understood that the more she was researching, the more she was just finding the same information. So she was able to contract to work to decrease that because she believed if she found more information, that was going to save her husband from cancer. So the information was going to save her. It was irrational. So she could find great information, but if his health was poor or he didn't get the treatment that was right for him, that was not going to prevent his death. And that's what she was trying to prevent. So she was able to contract for about an hour to an hour and a half a day. That's what we could get her down to because I knew she was never going to stop researching. That is what we've contracted to work her on. Sometimes, again, going back to what the client goals are, there's no way that she would have ever contracted with me to work to decrease it to no research. And actually it was important that she did some research on it because her husband was not in any shape to do some research on treatment. So it worked for her.
I have a client who, the one with health related OCD, and she has now what she used to do is go. Someone with OCD, health related OCD, often goes from doctor to doctor to doctor to get the response that they want. But what she's done is she said, I had a symptom for 2 weeks. I called my doctor. My doctor said, don't worry about it. I let it go. And so the fact that she waited 2 weeks is huge. And she went, that's gathering information. That's another example of gathering information. Like, I'm not going to look. I think she looked a little bit up on the computer, but not a huge amount. But she didn't go from doctor to doctor to doctor. She just got the information that's not something to worry about, and she was okay. The green, yellow, and red road. This comes from Anna Gomez when she uses it with kiddos, and I really love it. So the green road is, what can you look at right now? What can you change? What is the first symptom? It's like when we work with a lot of compulsions, I've worked with kiddos who have had an hour and a half compulsion at the end of the night before they could go to bed. What's the first thing you can change? And then we develop the adaptive coping statement. So that's the green. The yellow is a little bit more challenging, not so easy. And the red is not yet. And the red's like the last that you do. And that's where it's really anxiety producing for the kiddos and probably the adults. So, you get them to say, this is what I can work on. I'm going to do it. And they do it because they're also in control. You're not telling them you have to do this, this, and this. I always negotiate, but I also know that I'm going to continue to negotiate until there's some movement, so like, and also reinforcers, particularly with kiddos. You don't do that with adults. Just getting that space in their brain, not obsessing so much is really their reinforcer. We do have other offerings. We have new articles coming out. I don't know when. I know it's due in February. We finished the articles being edited. It's on OCD and PTSD, how they're similar and how they're different, and how you treat it. We also teach a course on ego state and EMDR. We have our distancing training, which involves distancing day 1. Day 2 is typically distancing in ego state because we both have clients who have DID or OSDD who also have OCD. And then we have the OCD and PTSD training and with a kiddo training. So those are the trainings that we do. Some of them are online through EMDRIA.
So that would be one of the ways that someone could find the trainings is to go to the EMDRIA website and look under distance learning. Where else would they find trainings that you're doing?
You could also go on KrentzelTattersall.com, and all of our trainings that we have available are on demand.
The other thing is that the one on EMDRIA, one of the ones on EMDRIA is when we were presenting in 2021, the distancing technique, we have really further developed into an approach. Also, we have an article in the journal last January, and in February of one in the Go With That magazine. So people can also go to those 2 articles.
Information is out there is what I hear, and that's really helpful for folks who are working with, I think, especially that subclinical OCD is probably more common than we're aware of. Because I'm thinking to myself, I don't have anybody with OCD. And then I can think of 2 people right off the top of my head now that have health-related worries, and that's definitely OCD stuff. So I think probably there are people I'm working with that have OCD, and it's just not the alligator closest to the boat. Maybe it's more of the post-traumatic stress from adult traumas with the folks that I work with.
And
Yeah.
there is a relationship between PTSD and OCD.
Is there?
And
Could you say something about that? What is that relationship?
So what they found is that the stressful life events, so there's a clinical interview, and that's the other thing I want to say is that if somebody is giving you a low Y-box um, score, and then you're interviewing them, you know that they're not giving you a true indication of how severe their OCD is. Cromer, Schmidt, and Murphy in 2007, they had a sample of 265 admissions to adult OCD clinic. They found 54% had experienced at least one lifetime traumatic event, and that the presence of additional traumatic events was associated with increased symptom severity. Adams and colleagues in 2018 found that the severity of obsessions and compulsions was significantly correlated with the number of stressful life events in the year prior to the onset of OCD and over the client's lifetime. They reported that those with exposure to traumatic events in childhood were 5 to 9 times more likely to meet the criteria for OCD. And those who had experienced sexual abuse were up to 7 times more likely to meet the criteria for OCD. And that patients with OCD report more physical abuse and neglect in childhood than anxious and non-clinical samples. So due to the plethora of research on the relationship between trauma and OCD, it's essential that you also do a trauma history and an attachment history as part of your treatment planning. And so that's an area that Jennifer and I work very diligently with, is those people who have both. And then you have to get at what's the underlying theme. I had a client who it was aggressive OCD, and the underlying theme with a trauma history, a sexual abuse history, underlying theme was safety. Like she needed to keep her child safe, and she didn't feel safe as a child.
One of the hallmarks, though, is that OCD attempts to prevent something happening in the future. If I do this now, I will prevent this from happening. And the OCD symptoms that are actually PTSD, they're trying to prevent something in the future that happened already in the past.
Such an important concept.
It's a really important distinction that this event occurred. One of the ways that we talked about it in our article is that and somebody who I work with somebody who believed that they would be assaulted in a bar, and they were assaulted in a bar, so they started avoiding bars. And that, yes, they might not get assaulted at a bar because they were avoiding bars, but that doesn't mitigate the fact that they could be assaulted anywhere else. But that behavior was aimed at safety because she had been assaulted elsewhere. So it actually makes, if you really start looking at it, it makes sense compared to OCD. Right? If I wash my hands 10 times, I'm not going to have any more germs. Well, that's not true. We don't know that. Or I'm going to prevent myself from being sick forever, or I'm going to, prevent something to happen from my family. We don't know that's true. But with PTSD, they're trying to prevent an event that happened in the past from occurring again in the future. And it has a function.
And both OCD and PTSD people have a high anxiety, and trying to prevent that anxiety from increasing. And so I think, Jennifer, what you just said, just to summarize, is that with PTSD, it's the past, and with OCD, it's the future. And so that's a simplistic way of describing it.
I did want to say something about, you said, I'm not sure if I have people with OCD. Paula and I hear that consistently after our trainings. I didn't realize how many people in my practice actually had OCD. I just didn't know what I was seeing, or I didn't know what to assess for, or I was really stuck with a client and they were circling, and I was, intervening in so many ways, and none of the treatment was moving. So once they started assessing for it and treating it, things shifted.
I have a client that had relational OCD, and I thought it was all trauma. And this is right around when the distancing was being developed, and I kept presenting her, and Jennifer and I were in the same consultation group, and she just wasn't getting better. And she was in group before she saw me, and in individual treatment. She no longer saw that therapist. She saw just me plus the group. She eventually stopped the group. And, she had a lot of attachment trauma, horrible parents, they would just say horrible things to her, like basically, that they didn't like her. And, she was the oldest and they passed her over to deal with the other children. And, she got a lot of messages, very clear message that she was not okay and not lovable. And it wasn't until I realized that she had OCD and I worked on the OCD that things got better. And I probably did like 15 or 20 traumas, standard protocol. And she got better, but not better enough. So I did the OCD work, and very quickly, because she had done all the trauma work, she didn't need to be in treatment. So what happens is as you do the PTSD work, and that the PTSD is going down, the OCD symptoms come up. If you do the opposite, if you treat the OCD and the OCD symptoms are going down, then the PTSD symptoms come up. And so you need to that's what our new training is about, is like, what do you treat first? Why do you treat it? How do you make that clinical decision? And can you do concurrent treatment to treat both the PTSD and the OCD at the same time?
I also want to say some of the exciting outcomes of the distancing approach is that people are using it with different applications. George Abbott in Massachusetts is using this with psychosis. They're using the distancing approach with psychosis. I know other people have been using it sometimes with eating disorders. I have used it with trichotillomania.
Well, thank you
Well,
again for your time
Julie,
and
thank you
willingness
so
to
much.
thank
share.
you so much. Thank you so
All
much.
right.
I really appreciate all of the knowledge that you're willing to share with people, and I want to make sure this gets out there so that people can learn and start using EMDR in ways that are going to help clients more.
Thank you so much.